So I've talked in years past about the things that we do with steroids and a lot of that kind of work. This year I want to talk a little bit about what we do in pediatric clinical trials. Specifically, a number of years ago, there was the Best Pharmaceuticals for Children's Act was passed, where Congress mandated to the FDA, when everybody was still working, that we were to evaluate drugs that are used to dose children that have not been studied. And so that wound up going through to the NICHD, and this group called the Pediatric Trials Network, which is run out of, or managed out of Duke Clinical Research Institute, got the contract with the NICHD to study these drugs. And so most of these drugs are off patent. They're old antibiotics, antifungals, things like that. But some of them are new drugs. I mean, who knew that we gave sildenafil to babies? So the PTN, where did it start? Where did it come from? It's really that to create an infrastructure for investigators to conduct trials, pediatric trials. So the guy who leads this, his name's Danny Benjamin. He's MD, PhD, MPH. I got more letters after his name than are in my name. But he's really just absolutely a brilliant guy, and figured out through work, spent time at the FDA, and figured out how to actually do pediatric clinical trials. And they're not done the way that standard clinical trials are done. But this network was set up, and there are about 35 sites across the U.S. We also receive samples from Brazil, CPSA Brazil. We receive samples from Shanghai and other places. So we're just following where CPSA goes. We're right there. This is an example of the kinds of studies that we do for them. So it's a pediatric opportunistic PK study. They call it POPs. And the key is these are opportunistic. Who is going to sign up their premature baby to be a guinea pig? Nobody, right? So all you're going to do is say, what does my physician think is the best standard of care? Physicians are treating children with drugs that are not approved. It's all off-label, if you will, officially, because there are very few drugs that have been studied in children. So it's up to the physician to decide what they think is the best way to treat a child. And then they'll ask the parent, if that drug is under study, can we get a little extra blood? Blood spots, plasma spots, urine spots, you name it, we get it. So in this particular protocol, what's interesting is normally there's one protocol and one drug. Here we've got one protocol, we've got 11 drugs that come in underneath that. And in fact, in the protocol, it gives a list of 30 drugs, and they're just going to pick the first 11 is what they funded. So whoever signs up the most, when they get enough drugs, they get enough to fill the cohorts, that's when it comes. And that's what we study. So it's a much more dynamic and fluid environment than a standard clinical trial. But we're looking at upwards of 1,000 children, 35 sites, and we started this in 2011. First publication from the first drug that was through the study was earlier this year, and it's rolling through. And so that's what we do. And let's go find a beer.
Thank you, Ken. Thank you for the beer and the presentation.